All right. Well, nice to meet you guys for starters, and sorry about having to reschedule, but here we are, and we will make it so worth your while. Mostly, we are going to help Suzanne, who is a Pilates instructor, but also to figure out because it's always difficult to do it for yourself. Like I had back surgery a couple months ago, but still it was like, what do I do? So we are going to look at you from the outside looking in. I'm going to share with you everything that I was just going through with surgery and treatment. We will do the physical assessment today. And I got on with her a few minutes early because I just wanted to check lighting and whatnot. So when you guys are if you're doing virtual assessments, which that seems to be the way things go these days. And the cool thing is, you mentioned Amman. I was in Amman right before COVID shut the world down. And you can train someone in Amman, you can train someone in New York, you can train someone in Europe. There are no limitations. So that's the one good thing with Zoom. I will say, it's more challenging and you have to get used to, what you're dealing with online because it's not palpable. You can't I can't say, "Oh, okay, I feel this, I touch that." It's all visual. So you want to try and control the setting as much as possible. And if you're dealing particularly with somebody who's older and isn't real savvy with the computer, maybe they can get a kid or a kid. My kid's 30, but my kid might be better to help me than what I can do on my own, or my 86-year-old mom. So check the lighting as best you can. I can't control what's going on in Suzanne's house. We work with what we've got. um, as I was explaining to her, we're going to do this in two parts. We're going to do upper body, we're going to do lower body. I'm going to do side, I'm going to do front, I'm going to do back, because if I have her stand all the way back against the door, we're going to lose details. So, it takes a little longer. Whereas, if you're there in person, you can just kind of go through the whole body. If you look, let me see, module 4. Do I have that one here? Hold on. Sorry. Up in the closet. Let's see. Okay. So in module 4, now we're going to be using module 3 for the most part right now, but I just wanted to share with you that you have all these documents that you can download. Uh, they are in your Teachable in module 4. Like afterwards, you're going to see a thing that says forms. So you're going to have all these forms that you can print out. And this one is awesome. I wish I'd take my own advice and print them out, but I'm just using like a scrap paper. So this has all the postural assessment. It has all the gonimetric measurements, Thomas test. Everything's in there. All you need to do is fill it in. So that's nice versus, this is what I'm doing right now. It's also nice if you want to send a copy of that to like the physical therapist or the doctor, to kind of create that communication, and you're starting to brand yourself and build that know, like, and trust relationship. So the more professional, obviously, that we can be, like I would never send this to a doctor. Now, by the way, I didn't ask you, Suzanne, did you or do you work with a physical therapist?
Not yet. I actually have to see occupational therapy at the end of the month for an assessment of lymphedema on my left, triggered by possibly radiation. So
Okay, so you think you do have lymphedema?
I have some peripheral neuropathy in my left, and from my elbow down to my fingertips is pretty painful now, and it's becoming a problem. So they're just evaluating possible lymphedema. They suggested the cording that we looked at in some of our lesson planning.
Mhm.
Um, so
Okay. Any peripheral neuropathy in your feet,
not as much as my upper extremity.
but some?
Some,
Okay.
yeah.
All right. So when you guys, you're going to get your client's health history, and then there's a lot of questions you will come to ask. So, Suzanne gave me the basics, and then I'm like, all right, let's fill in the blanks here. So she's 51 years old, recurrent breast cancer, finished chemotherapy in November. Now, I'm going to tell you what to think about between now and when we actually put together your workout. So when you go into module 2, and even though I know exactly what kind of chemotherapy she had, we can pretty much lump it all together for the most part with the acute and chronic side effects. So the acute side effects are those that happen during chemotherapy or shortly thereafter. So she's in the shortly thereafter stage. And that can be low blood cell counts, that can be vomiting and diarrhea, that can be cancer cachexia, which is muscle wasting. In
Yeah.
some rare cases, it could be weight gain. Obviously, people lose their hair, nail issues, those types of things. So those are your acute side effects. Your chronic side effects are your increased risk for osteoporosis, diabetes, damage to the heart and lungs. It can increase your risk for future cancers. And there is a very little bit of evidence that suggests that chemotherapy may increase the risk of lymphedema. So lymphedema being the swelling, in this case, of the extremity. Now, oh, you know what I forgot to ask you? You had nodes removed?
So the first time I had the cancer, I had 9 nodes removed, sentinel and
On
axilla,
which side?
both.
Okay. All right. So that means that she is at risk for lymphedema on both sides. Okay. And the fact that she is also just finishing up, I mean, it's photon therapy, but still with radiation and the burns to the skin, that also increases the risk for lymphedema. So we're going to build this out next time, and you'll see how I do it, where we look at like kind of how many red flags we have for each thing. So I'm like, all right, well, already I'm going, lymphatic drainage is going to be a big deal.
Yeah.
And you just told us that they already suspect that there may be some lymphedema and some cording. So immediately I say, I know that we're going to be doing lymphatic drainage exercises, and we're going to start and progress slowly with the upper body because we don't know what her body can handle. Now, in that same breath, I'm going to ask you, and this can be between now and next time, to send me any exercise that you are currently doing,
Mm.
cardio, heavy bag, whatever. I want to know where you're at because I'm going to meet you where you're at. Now, if I think you're doing something like hitting that heavy bag with punching gloves, I'm going to tell you not to because that is going to increase your risk for lymphedema.
This curriculum has taught me that the plastic surgeons have never told me not to do work out with a tissue expander. And it popped out, like you said, and then I
Yep.
was pointing that way.
Yep.
And he
And
was just
and
like, why
and
is it doing that? I don't know.
yeah. And so,
So,
but you will have doctors. This is where you guys have to use
yeah,
your education because doctors are not trained in exercise. Doctors are
correct.
not trained in nutrition, unless you're dealing with an orthopedic doctor. But I err on the side of caution. And so we have 20 medical advisory board members, and I go based on what they have told us, which is when there is an expander in place, there is absolutely no chest work, which means there's also no back work because you've got eccentric and you've got concentric movements. So if I'm doing a row, I'm stretching my chest. If I'm
Mhm.
doing a chest press, I'm shortening, so I've got the concentric and the eccentric. Once that expander comes out, and we replace it with an implant, then we start the clock for 6 weeks with recovery.
Yeah.
And so then, no matter how much progress we make between now and then, you're going to go back to wall walks, range of motion, and you'll probably go a little quicker than the first time around. But if you jump the gun, then you end up setting yourself back, i.e., the implant comes out of its pocket, whatever.
Yeah.
Now, in the meantime, other than she shared with me, we've got Achilles issues, we've got back issues, we've got
Knees. You didn't
uh,
know about
oh,
knees?
knees too. Cool. So we'll see all this as we do the assessment. But other than that, there are no limitations on the lower body. So we
Right.
will choose corrective exercises to address any muscle imbalances. With the upper body, whatever the situation is, we're going to only introduce one or two exercises to begin with based on the postural assessment and range of motion, and see how your body tolerates it. If there's no swelling, if there's no additional swelling, pain, neuropathy, then the next time we can either add more reps or add a teeny bit of resistance. We don't go from 1 pound to 5. We go from 1 to 2 to whatever denominations we can come up with. We go, green band, yellow band, red band, blue band, because if I go from a green band to a red band or whatever, depends on what brand you're buying, but if I go from ultra light to medium or heavy and you get lymphedema, I don't know that maybe if we had just done light, you would have been fine. We did too much. I also know that I don't have anything, you are not going to be wrapping a band around your hands like this. you're going to be holding the band between your fingers if you're using bands, because doctors won't tell you this either. It restricts blood flow, which also restricts lymphatic flow. That's why they say don't get blood pressure taken, don't have blood drawn. Because you've had it on both sides, technically, they should be using a leg cuff or taking your blood elsewhere. So, more often than not, you will not encounter somebody who's at risk on both sides. But when you do, you need to know these things. So I'm going to tell you, and I'm actually excited, Suzanne, that you're complicated, because this is going to be it's a learning experience. I'm complicated too.
Absolutely.
I mean, orthopedically, I'm like, so you're not alone. You make it to this age, you're like, something's going to be
Yeah,
messed up. So,
sounds right.
finished chemo. We're not like in the acute phase, but what are your blood cell count? Are you still immunocompromised?
Yes, and I'm still anemic.
Okay.
My platelets look better.
Okay.
Yeah, but they still classify
So
me as anemic.
low red blood cell count, not necessarily iron deficiency.
No.
Okay.
Mm-mm.
So with a low red blood cell count, with low platelets, we want to make sure that our clients are not in a situation where they could trip and fall. Avoid bumping into things. So now's not the time to go rollerblading or downhill
Right.
skiing or,
Whoops.
jumping out of an airplane. Oh yeah, well, I won't tell anybody. I'm going to invite you out here because I'm a mile from Beaver Creek.
Oh,
So
there you go.
we'll celebrate you. Okay.
Mhm.
Now she also in the 80s and 90s and most currently in 2014 had multiple abdominal incisions to remove ovarian cysts, ending with a total hysterectomy in 2014. So you have a horizontal incision?
Yeah.
Okay.
And a C-section for my daughter, of course.
Okay. So there's probably a lot of core compromise, which may have then led to in 2015 having let's call it a lumbar laminectomy, L4, L5, S1. Okay. Um, 2016, double mastectomy,
Yep.
immediate implant, well, expander to implant.
Correct.
And then, okay, in between that and the recurrence last year, she had in 2020 bilateral Achilles reconstruction. So I know this has nothing to do with cancer, but this definitely is going to have to do with the workout program.
Absolutely.
And then in 2024, what did you found a lump?
Yeah, I felt a nodule up in my left chest wall. I went to the oncologist at the VA who was tracking me. And then she said, wait and watch. I didn't like it. So I went to a civilian oncologist who deemed it important enough to check it out. And yeah, it was,
And I'm so
yeah.
glad.
And this time it's HER2 positive, which it wasn't HER2 positive the first time.
Okay. And on that note, you guys, I've had 17 biopsies. I tell people never watch and wait.
Yeah,
Ever.
it's
I don't
ridiculous.
care who tells you that. I don't care if they're the most prestigious doctor on the face of the earth. It is your body. You are in control. And I can't tell you how many times I've heard people say, I watched and waited and it ended up being stage whatever, whatever.
Yeah.
So,
Yeah.
it's stage 3 now by the grace of God. It's not stage 4 because you took control of that one.
Absolutely.
So bringing us current, you have an expander in the left side.
Mhm.
The implant is still there from 8 years ago.
Uh, Let me interrupt that. They had to replace it. There was a recall on the textured implants.
Okay.
So they did that when I moved back here in 2021.
All right. Well, that's good. You don't need to do it for another 7 years or so. So, and that's the issue with implants is you're going to have to replace them.
Yeah.
Anyone who has implants for breast cancer or augmentation, roughly every 10 years. So we're taking all of that. That is the health history. And if you think of anything else, but you can let me know later. But now we're going to go on to the postural assessment. The postural assessment is hands down the most important thing any of us as a fitness professional, or a physical therapist, occupational therapist, whatever, can do. I look back 30 years ago when I started as a trainer and I just randomly picked two chest, two back, two shoulders, two bicep, and I think, God, I did people such a disservice. Whether you are training, young athletes or you are teaching a silver sneakers class, the postural assessment is going to let you hone in on what this person should be doing, not necessarily what everyone else is doing. And we'll have time to talk where I'll talk about like how you can modify things if it's in a group setting, and how can you individualize things even when you're teaching a yoga class or a Pilates class or a Zumba or whatever. So I had asked Suzanne ahead of time if she was comfortable to wear a tank top or a t-shirt, preferably a tank top, and then shorts or pants that she can roll
Yeah.
up over her knees. Now, if you have a client who is like, absolutely not, I'm not going to push it. I'm just not going to get as quality of an assessment as I will, the more I can see. So hopefully you're not freezing. When we do your lower body, you can put your little jacket back on. But whenever you're ready, we'll go ahead and have you take your jacket off. And if you have shoes on, you're going to want to take them off. If you have socks, you can leave them for now, but we'll take them off just for a real quickie when we look at your feet. But we'll start with your upper body.
Okay. I'm
Okay.
sitting on a yoga
Bouncy
ball.
ball. Okay,
Yeah.
yeah, we'll kick that out of the way for now because I'm going to have you stand up.
Okay.
The reason we do not want people to have shoes on is because if they have orthotics or any kind of lifts in there, it's going to give a false impression. So I can already see your left hip is higher than
Oh
your
God,
right hip.
yeah.
So when
Yeah.
you're doing this, I want you to be as natural as possible. And I'm actually going to have you come a little bit closer because I'm not even going to worry about anything right there. Perfect. We're going to focus on that part of your body right now. So what I need to see is from the earlobes to below the hips.
Do you want
That's
me on my knees?
no, you're perfect. You're
Okay.
perfect.
Okay.
Okay. Um, Now I am going to ask you, and don't do it yet, but I'm going to ask you to close your eyes and march in place for about 5 seconds. Now, knowing that you have peripheral neuropathy, and if it were anybody, if I was afraid of them falling, then I'm not going to make them march with their eyes closed, or, there's something next to them that they can lean on, that type of thing. We never want to risk injury. Oh, you noticed that was a little askew?
Yeah, absolutely.
Perfect.
I was driving
So
crazy.
if you guys didn't see that, it looked like she was slightly rotated, which she may end up being, but we want to try
I
and
like
make sure that our camera or our computer or whatever is square. And especially if people are using tablets, they have a hard time getting it kind of perfect. So when you're ready, and just to let you know, I believe it's 16 in module 3 is the postural assessment chart. You don't need it for right now, but this is what you're going to refer to make your life really easy. When I look up forward head, rounded shoulders, pelvic tilt, it's all in there. Tells you which muscles are tight, which muscles are weak, and then we've got suggested exercises, okay? So the good news is 99% of these things can be corrected with the appropriate exercises. So go ahead and let your hands hang just naturally, loosely. Take a couple marches, and then once you land in place, you can open your eyes and try not to move. Okay?
Okay.
So just a couple seconds, a couple marches. Okay, perfect. So try and just be like a statue. If you do have to move, I'll just have you march in place again
Okay.
to kind of reset. All right, so try not to move. What I'm going to do is I'm actually going to take my pen or any, piece of paper right up to my computer, and I'm going to go to her earlobes. Now, the first thing, and I know we're looking up a little, but it's not distorting it, so it's okay.
I
Um,
can adjust it if you want me to.
like you can make it go up higher a little
Yeah,
bit?
I can move my box up.
Okay, all right, we'll do that.
I'm sorry.
Now, sometimes you'll have people that will have their computer like on the floor and you're looking up at it, and that definitely does not work. You want them to try and, stack it up. So the more level we can have everything, obviously the better, but you're not always going to have a perfect situation. Oh, okay.
Is that
Fantastic.
better?
Yeah, now we'll probably have to have you go back a little bit further
Yeah,
though.
absolutely. I'm going to take out my extension cord here.
Okay. Yeah.
Okay.
No tripping allowed.
No
Okay.
tripping.
So maybe step back another step and then go a little bit more to your right. Perfect. Okay. So just go ahead and march in place again, a couple steps, eyes closed, and then once you land, try not to move. Okay. Beautiful. All right. Now, I can immediately see, what's going on that left shoulder. I can see the protraction. You can see that shoulder. It's hard to tell if it's elevated or if it's pulling forward. We'll see that more from the side, but I can look at the trapezius on the left side and see this is more defined. And that doesn't mean it's more muscular or you're working it out more. It's compensating for everything that's going on. It's trying to stabilize that side. Now, what I'm going to jump back up to your ears. Your ears look level. What I do notice is that I see more of your right ear than your left, not by much. But what that means is that all of that tightness that I can see going on in that left shoulder area is probably slightly pulling your head toward the left. Very common. And the good thing is the lymphatic drainage exercises include neck stretches. So we can kind of kill two birds with one stone during the lymphatic drainage exercises. You just spend a little more time doing the neck stretches. So I'm going to just start making notes. I'm just going to make a little arrow up and then put left shoulder, which to me means elevated left shoulder. And I'm going to put very slight rotation of the head. And then I do a lot with arrows. So, for me, it's like elevated shoulder and then, rotated to the left. You guys write it however you want, and you can make it more professional later. The next thing I'm going to do is I am going to look at your elbow creases. And first off, your left arm is closer to your body than your right arm is. And I think that's more something going on with your hip, which we haven't addressed yet. But I'm just making a mental note. I don't necessarily have to have the answer for why everything is happening right now. I just know it is. Now, are you in a good amount of discomfort? I don't want you to be hurting.
On my left side?
Yeah. I
Yeah,
know. I'm pointing to my right. I meant to, I meant
no,
my left.
it's fine. I get it. No, it's very sensitive, but it's not like super
Okay.
painful.
All right. Just let me know if at any time you just need to rest or
I will.
stop. All right. Now, the next thing that I see noticeably is it looks like the left hip is higher than the right. Now, that could be a number of things. I didn't ask you, do you have scoliosis? We talked about
So
the degenerative disc.
in one of my scans, it did identify, scoliosis mild, which was in my cervical spine, which
Okay.
was surprising.
Okay. And that is not going to affect what we're seeing here. I mean, you would have to have severe scoliosis
All right.
to have that hip elevated. Now, there can very likely, based on everything that's going on here, all of those muscles on your left side can be seizing up. It may be all muscular. So that's one possibility. Another possibility is that you have a leg length discrepancy and
Hmm.
that your left leg is longer than your right leg. I doubt there's that much of a discrepancy because I'm going to say there's probably a 2-inch hip hike on your left side. I think someone would have mentioned that, at this point in your life, like, oh, wow, we need to do an x-ray because your left leg looks 2 inches longer.
So when I did the bilateral Achilles reconstruction, and I kept having all these Achilles issues for years, which is why he ended up doing what he did. Um, it was mentioned as something to that effect, but it was nominal. So he said it wasn't really something to worry about.
Okay. Okay. Now that also there could be compensation going on because you said they did something with your gastroc, like they extended your gastroc. So we've got a lot of possibilities here, and
Yeah.
this is what I actually love because you're like you're putting the science back into exercise.
Yeah.
So right now I'm just going to put elevated left hip. I don't have to have an answer for it. I'm just making a note of it. All right. Now I'm going to spotlight me so you can see me a little bit more because I'm in all black here. And I'm going to, this is what you guys are going to try to convey to your clients who are not fitness professionals. So the ASIS, your anterior superior iliac spine, I tell people basically just bang, knock, and you're going to feel a bony thing. Now, if somebody's morbidly obese, they're not going to find it. Don't even try and get them to because it's going to be an exercise in futility. Okay, so the first thing, and you can relax for a second, but I'm going to have you identify these when you're standing straight, and we're going to look and see if we have any rotation. Do I see more of one than the other? Okay, that's the first thing. The other part of that is when I have you stand sideways, you're going to find that ASIS, and then you're going to find the PSIS, the posterior superior. So again, the little bony matter. And what I'm going to have you do is bring your arm around like this. So if you're doing this to me, I want your fingers to be like this. Now, if we have an anterior tilt, it's going to look like that. If we have a posterior tilt, it could look like that. Okay. So first we identify these, then we do this. And then lastly, or firstly, whichever you want to do, we go to the iliac crest. So I tell people, think of a horseshoe and push your fingers in. You don't have to lift your shirt up. You can do that. I just want you guys to see what I'm getting at. And then I want to see your fingers. So I expect that we are going to see something like this with that. I'm doing my right hip because I'm just trying to mirror you. Okay, so let me get my eyes back on so I can see you. And then let me unspotlight myself here. I can figure out how to do that.
You know, what's interesting, if I can add, as I
Uh-huh.
was poking around, and I didn't mention it because there's no diagnosis for it, maybe that the sensitivity in the musculature and tendons as you touch that down the leg on the inside and the outside of the thigh and the low back and right there at the glute medius kind of
Okay.
piriformis area. Super tender. Just haven't figured out the whys on those. So that's
Well, I mean, it's probably got a lot to do with the chemo,
yeah.
and just muscle soreness, joint soreness, and all of those things should get better over time. I mean, you are literally coming out of the thick of this. I mean, you're still in it, you know.
Yeah.
So when you have a client who, oh, what about your energy level? How's your fatigue or lack thereof?
It's better.
Okay.
So it is better. It
Like
was pretty bad for a while, but that was, they said it was the anemia, and
for
I
sure.
almost passed. I passed out twice.
Okay.
So infusion 4, they started reducing my chemo because
Okay.
my kidney function and liver function wasn't appropriate.
Okay. So on a percentage base,
Yeah.
with 100 being your normal you, what
Mhm.
percentage of energy would you say you have?
I'm about a 75, I would say, maybe close
Okay.
to 80. I
Which
feel a
is
lot better
pretty
than I did.
spectacular for
Yeah.
what you've just been through, you know? I mean, your body's just been through like a war, and you know, you're still fighting. So, you know, remember guys, you've got the emotional and the physical both are going to cause fatigue. So when somebody has severe fatigue, or we're starting, and this depends on what you tell me when you share, you know, if you've been exercising or not. The first session is going to be like 20 to 30 minutes. No
Mhm.
one is starting off with an hour-long session if they are either going through treatment or they've done nothing. Um, because again, we need to see what somebody can tolerate, not just because of lymphedema, but because of aches, because of pains, because we don't want you to faint. You know, and I already said, you know, with having low red blood cell counts or low platelets, you know, if you do fall, you're more likely that you're going to have more bleeding or bruising because the platelets are low. So just you want to just be very sensitive to all those things. If somebody has peripheral neuropathy in their feet, even though yours is mild, I'm probably not going to put you on a treadmill where if you lose your stepping, you're going to go flying off and you're going to end up getting hurt. If you have peripheral neuropathy in your hands, we want to be careful with anything involving fine motor skills that you could drop a weight or you could, you know, let go of a band and snap yourself or somebody else. So we'll get into all this as we get into the exercise programming. So for now, if you can step back maybe one step, and let's start with your fingers. Think of the top of the hip, the iliac crest, and just like if you can try and make a straight finger. So, okay, first are you on the ASIS right now? Okay, so
Mhm.
we'll start with that. We'll start with that. Then we'll go up to the iliac crest. So the cool
Oh,
thing,
sorry.
no, you're fine, you're fine. You've got these lines on your shirt, which is kind of cool. It's like a graph. It's like, oh, it's on the same line.
Ah,
Okay. So I'm trying not to let my eye go because I think your iliac crest is definitely higher on the left side. Can you do just one finger? So, yeah,
sure.
yeah. All right. So visually, your ASIS look relatively the same. The left one might be a little bit higher. It does not appear that, and you guys feel free to chime in because you may see something I don't see, but I feel like you're rotated a little bit, but it not reflected in where your fingers are at the moment. I think it's more what's going on at the hips. So let's come up now to the smallest area of your waist above the hip bones, and see if you can get that same horizontal thing going with the fingers.
Do you want me to look at?
Can you see me when I'm showing you? Can you see me
No,
now?
you don't have a picture on right now.
All right, let me do this again then so you can see what I'm talking about.
Yeah, I don't see you.
Sometimes it does, sometimes it doesn't. I hate Zoom
There you
sometimes.
are.
Okay. I want you here, okay? And give me fingers like this if you can.
Fingers like this.
Yes, yes. But now I got to get rid of me because I take up too much of the screen and I can't see you. All right, there we go. Okay, so give me just one finger if you can, just your index finger. I think, yeah, your shirt's confusing too because it's like on the same line, but I know your left hip is higher than the other
No,
side.
yeah, the shirt looks. I remember I only have a tissue expander on the left side, so it's not
Yeah,
as robust as the right.
it will be, honey. It will. All right. Well, I'm
Uh,
definitely going with the elevated left hip. Now let's have you turn and face the side, okay? And you're going to take your right hand to your left ASIS. Yepers. And now you're going to take your left hand to your left PSIS. So you're going to the back. I mean, I can see you have an anterior pelvic tilt. So, everybody's got, usually people have a little bit, but she's probably like 2 inches up in the back. Yep. And so when you pull in that abdomen, and after all those abdominal surgeries, this comes as no surprise. And then you've probably also got tightness in the lower back from, having the back surgery. And then, we've got this balance of weakness and scar tissue. And girl, if you could have like, $1 for every gram of scar tissue in your body, you'd probably be rich. All right.
yes. Yep.
All right, go ahead and relax. So I'm putting anterior pelvic tilt. Now, while I still have you by the side, go ahead and face that way again. Try and shake it out. Just relax because I don't want you to try and stand up straight.
I know it's a habit.
I know, and that's good. That's good. But today you're off the hook. So now I'm going to take my pen and I'm going to go from her earlobe down to her clavicle. Now, in a perfect world, the earlobe should be lined up in the center of the clavicle. So if you think of the clavicle as like a coat hanger, it should be like in the middle of the triangle. You actually have very nice posture. Your head is slightly forward. So if you retract your head, just go ahead and humor me with that. Okay. That's probably a little overcompensated, but that's about where you want the ear. So we know that like that's what we're going to strive for. So I'm going to put slight forward head. Go ahead and get back into whatever your head wants to do.
Okay.
And are you doing okay?
Yep.
Are you too cold?
No.
Okay, okay. All right.
Got a
So,
heater right above me. Right there.
oh, okay, good, 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 good. Where are you in New York? Where did you say you were?
Oh, Virginia.
Okay, because I was thinking if you worked at the Pentagon, you got to be in the DC area, but for some
Yeah,
reason
I'm in
I
DC.
had New York in my head. Okay, I'm from Rockville. Okay,
Oh, okay.
Maryland, Maryland. Okay, so now we can also look to see, and it's a little hard with the lighting, but I know that shoulder is protracted, and I can see the burn on your back also. So we're
Yeah.
with
It's better
radiation.
with the light out.
That's not bad. Yeah, that's good. Radiation is like a sandwich effect. It's going straight through. So
Yeah.
you can get a burn in the front, burn in the back. You can get lymphedema in the front. You can get lymphedema in the back. So there could be swelling, anywhere in the lat area, the pec area. Okay, so let's go ahead and go 180 degrees so we can see your other shoulder and see if we notice any difference. I definitely think that the other one, I mean, it's hard to be specific, doing this virtually, but I think it's pretty noticeable that the left one is tighter and pulling forward. So I'm going to put forward shoulder. We can call this upper cross syndrome. You can get fancy however you want, but more noticeable on the left for sure. All right. Now I'm going to have you face the door, the back door, or the one. Yeah, perfect. What I am looking for here, and I think, can you look down at your feet and see if they're level, like in the same place, or if your right foot is further back?
My right foot is further back.
Okay, can you get kind of equal?
Yeah, they're equal.
Okay, perfect. So now I can kind of reconfirm what I already saw, which was the left side was elevated on the shoulder, on the hip. I can look at the ears being level, but what I can see now, what I'm looking at is the shoulder blades. Now, I want to say that we've got some winged scapula on both sides. I want to say that the left side is a little more, and it's kind of hard because my eyes are drawn to where that radiation burn is, which makes it seem like it's more pronounced. But it would make sense that there was more winged scapula on the left than the right. So I'm going to put winged scap, and I don't need to because it's on both. There will be certain exercises we will do for that. I'm going to let you put your little jacket on if you like, and just take a break for a second so I can explain something. So when somebody has a lymph node dissection, particularly an axillary lymph node dissection, so you said and I want to make sure everyone understands this. You said you had a sentinel lymph node removed and 9 lymph nodes in total.
2 sentinels and the rest were axilla. Yeah.
Okay. So what a sentinel lymph node means is it's the first node or 2 nodes that receive lymph drainage from the actual tumor. So they put a blue dye into the tumor, and then that blue dye travels into the lymphatic system. The first node to turn blue is the sentinel lymph node. When they first started doing this, which was about 1995, they said you cannot get lymphedema from a sentinel node biopsy. That has been thrown away now. You can get lymphedema, but your risk is half that of what you would have with an axillary node dissection. The greater the number of lymph nodes removed, the greater the risk of lymphedema. And then you add radiation, that doubles the risk. So right now, if I go with my charts, it's roughly like a 17% chance of lymphedema with like multiple nodes, okay? Let's say an axillary node dissection, and then that doubles with radiation. Now, then there are other things, as you'll read in your book. The older somebody gets, the higher the risk. Poor nutrition, higher the risk. More body fat, higher the risk, because the body fat retains, the adipose tissue retains fluid. So all of these things are factors, and we have to look at nutrition. Now, when I say look at nutrition, she is currently undergoing treatment. That means unless you are a registered dietitian, you cannot, in good conscience, make dietary recommendations to someone who is going through treatment. Now, you're not, are you not on hormonal therapy because you've already had a complete hysterectomy?
No, not yet. He's going to again. I was on Arimidex first for the first 4 years, and then tamoxifen for 3 years. Took me
Okay.
up to tamoxifen, got cancer. Now he's going to go back to an AI like Arimidex
Okay.
after
Okay.
radiation's over.
All right, so those are designed to stop or block estrogen. So
Yep.
estrogen receptor positive tumor, the tumor grows in the presence of estrogen, so we shut down the estrogen, with the goal of stopping that. Now, most people gain weight on those. Did you? Okay.
Yeah.
Uh,
I'm almost 40 pounds overweight right now.
So 25
25 from chemo.
pounds is about how many?
I gained 25 from chemo during
Interesting. And
chemo.
that's what I said. See, some people lose on chemo, some people gain.
Yeah, I
So
thought I
the
was going to
weight
lose. I didn't lose.
We're going to fix you. Okay, well, let me
Okay.
get back to my original point. So,
Okay.
because
Yes.
you are currently undergoing treatment, and when you're done with chemo and radiation, you're going on hormonal therapy, which you'll be
I
on
am.
for years, you guys cannot make nutritional recommendations unless you are a registered dietitian who specializes in oncology, because there are different things, herbs, supplements, foods that, grapefruit is a prime example with chemotherapy. And if you don't know that, it can interfere with the efficacy of the treatment. So
Wow.
while someone's on treatment, you refer them to a registered dietitian. If you need one, you reach out in your Facebook group, the Cancer Exercise Specialists. If you have not joined the group, you should, because you've got a network of a couple thousand people around the world, doctors, nurses, PTs, OTs, nutritionists, personal trainers, yoga, Pilates, you name it. Now, I have a master's in functional nutrition. I I can do it, and I will for you. However, it is not my specialty. Exercise is my specialty. And I would say if you can get a dietitian covered by insurance, do it and get
Yep.
somebody who specializes in oncology.
All right.
Weight gained, particularly on hormonal therapy, is very difficult to lose while
Yeah.
on hormonal therapy. So we have to set realistic expectations and work more on building lean muscle mass, which is going to increase your metabolism. You're going to burn more, more calories an hour. I know it's frustrating. I can see it in your eyes, and I'm going to help you as much as I humanly can, which is what you get in return for bearing your soul and your body to us to,
Here
to
I am.
learn to learn from. So that is what I give you back. All right, so we've done the upper body. Now we're going to do the lower body. Now, obviously, you could do a much more thorough postural assessment, but I've been doing this for 30 years, and I can tell you that the way I do this, I get just about everything I need to know, and 99% of the time, not only can I, correct these muscle imbalances, but that results in less pain because with all of these muscle imbalances, you've got muscles that are in spasm, and then the spasm is oftentimes what causes the pain. So like if you're having burning in your chest, a lot of times, I mean, you've got expanders in there right now, stretching the skin, but a lot of times it's literally just because the muscle is constantly in spasm, and so you're not getting blood flow to that area, so it's not healing.
Okay.
All right, so we're going to move on to the lower body. We're probably going to with your camera. So now really all I need to see is from above the knees down. And at this point, if you do have socks on, if you can bear it.
No, I took them off, so I'm trying to
Okay.
see what's the best vantage point as you are.
Okay. So if you go back more, so I can see your feet, that'll be perfect right there. And you can zip up, you can make yourself warm, you can put your hood on, whatever you want to do. Okay, so we've got to get back. Oh, can you get the pants up over your knees so we can actually see your knees?
Uh-oh, no.
Well, if you can't, I will just have you like, okay, you did it. Yeah, did it. Uh,
That
try,
worked?
I'll try not to cut off your circulation here.
It's okay, but yeah, so I did notice that I have a lot of swelling from the knees to ankles.
Okay.
Um, and I don't know if that's from the Achilles reconstruction with scar tissue or,
Can you get that left one up a smidge more?
yeah.
Well, I do want to bring this to your attention because particularly following chemotherapy, and they are going to be checking your heart and making sure everything is good. I
Yeah, I
don't
had an echo
I
today.
don't think you have congestive heart failure, but that is something you want to be on top of because with congestive heart failure, you can also get edema. That is not lymphedema, that is edema. It is swelling having nothing to do with the lymphatic system per se. So you do want to be aware of that, especially, if you have any pain and usually I think from my experience it's on one side. But um we'll also have you do lower body lymph drainage exercises just because. Why not? Maybe it'll help. Without doing anything, I can already see you got stuff going on with your knees here. Um, so I'm actually going to have you step forward just so your toes are back a teeny tiny bit. Perfect. So if you can be like right about there, I just get a little closer. We're going to march in place again with your eyes closed. Really important to let your feet land wherever they want to land, however they want to land, and just stop
Wow.
whenever you. Okay, perfect. All right, so leave it be. Now, even before your foot inadvertently turned out, I noticed that your knee was laterally rotated. So the left knee is laterally rotated and the foot is going with it. So what that potentially is doing is going to cause supination in that left foot. Do you feel more pressure on the outside of your left foot, meaning baby toe, versus big toe, or do you feel that you're rolling inward on your big toe?
I
Because
don't feel that at all on either side.
okay,
I
okay,
feel more of my heel, which
okay. And with all that Achilles tendon stuff, that comes as no surprise. But I'm gonna note left knee laterally rotated.
patella
The
maltracking has been a thing. So
what has?
patella maltracking and
Okay,
the
okay.
rubbing.
Yeah, yeah. And did you go to physical therapy for that?
I hate physical therapy. Let's just
Okay.
know that. I
All
did
right.
cortisone for the longest time, and then they told me no more cortisone.
All right. Well, we'll fix you up. I'm coming to Maryland in a month. Maybe I'll come. All right.
Great.
So the other thing that I think is that you've got hyperextended knees. Actually, I think the right leg is hyperextended. The left knee looks like it is more bent than the right knee. Now, that also may correspond with that right leg being elevated. It could have to do with the fact that your quads are really tight, which is pulling on your hamstring, which appears to be lengthening that leg. See, go ahead and bend your right knee a little bit. Well, that was a lot of it, but you get the drift. Look how you see how the hip just went down. So there's a lot of anomalies here that we just have to kind of experiment with. And the great thing about strengthening and stretching is it's not surgical. If you do it in baby steps, it's either going to work or it's not. And if it doesn't, you try something new. You know, it's not like having a facelift and you don't like the results and you're like, I'm SOL. I mean, we can try different exercises. So I'm gonna say right knee hyperextended, and we'll be able to tell more from the back also. And then left foot rotated laterally. You know, and it's interesting because, and this is where not being there in person, it's kind of hard. It looks to me kind of like your foot is rolling inward, i.e. pronation on the left foot, but that would be very complicated with lateral rotation of the knee. It usually goes the other way. So let's go ahead now and stand sideways again. So you'll do the march in place again, just to kind of reset. Okay. And so from here, it's interesting because on like in my view right now, I can see, even though I can barely see it, I see more of your right calf. So your right leg appears more bent and your left knee is locked out. When you stand, do you just inadvertently lock your knees?
It could be years of 26 years of military service,
That's
but
kind of what I was thinking, but I didn't want to
I,
like go there. Like,
I mean, we're conscious of not locking out our knees, right?
yeah,
Sitting
because
at
I mean,
attention.
you
So
have really good posture, but I could see like the stiffness, you know.
yeah.
Let's go ahead and face that back door or the whatever door that is. You got lots of doors. Okay. Can you step forward just a smidge? Okay. And then do a couple steps in place again. Okay. Relax. Now also notice from the back that both of her palms, if you were to straighten out your fingers, are facing us. That is an indicator that rounded shoulders, because as the shoulders round forward, so do the hands, and the palms then face backward. All right. So you know, all things considered with your Achilles, they're looking pretty good. Now your right foot, do you feel like that one is rolling in at all? Do you feel more pressure on your big toe?
I feel more pressure on my arch.
Okay. Yeah, like so you're rolling into pronation on the right side. Okay, so right pronate. And the left actually looks pretty good. Yeah, I can see the scar from the Achilles tendon. Now, how come I can only see the scar on the right leg?
Because that's when I was saying the graft that he put to reattach the tendon,
Okay,
my body rejected it. So he
okay,
had to go back in, take it
gotcha.
off. And then he opted not to do that on the left side. He
Okay,
just
all
did it
right,
because of lengthening.
that makes sense. Okay, all right. Now when we look, here's an interesting thing. I mean, it does look like the crease in the back of your leg is a little bit higher on the left than the right, which would go along with the left hip. But I think that your quadratus lumborum, your QL, which to the left of your erectors in your spine, I have a feeling that's the culprit there. I think you've just got so much tightness going up this left side. So that's where I'm going to start from. I don't think like you can turn around and face this again. I think that if the doctor would have made it more apparent that you had a severe leg length discrepancy. So, and we'll talk about all of this when we're actually doing the exercise programming. So, um, one more thing while you're standing, I want to do, can you do a squat or will that
Mm-hmm.
cause you pain? Okay.
No,
So
I can do it.
I'm gonna highlight me again because I want to show you how I want you to do this. And you can actually staying right where you're at. I can see everything I need to see. You can't see all of me, but stand normal. I want you to try and get your arms up. I mean, I don't know how well you're going to be able to do that. Number one is I don't want you to be in pain. So at any point, if you're like, this sucks, I don't want to do anymore, then you stop. Let me unspotlight me again. Remove spotlight. Okay. So guys, what we are looking for as she does this, we are looking to see if the arms fall to the side. We are looking to see if she bends forward at the waist. We're looking to see if the arms fall forward. We're looking to see if the knees collapse in or if they bow out, and we're looking at the feet. So just a couple of them. And again, if you it hurts. Okay, so we're definitely bending forward at the waist. I don't see any too much movement in the arms, which is pretty good. And the knees.
The knees are making lots of noise.
Okay, okay. Go ahead and relax for a second. So there's definitely the forward bend. Now, while you can't get your arms completely straight up and down, I didn't see the left side coming out into abduction. Do you feel the expander when you're doing that, holding your arm up?
No, I feel the burn. The burn is really like
I'm so sorry.
underneath my armpit.
Okay. I don't want to push you to do more than you can. So,
You know what? It's fine.
all right, let's try this from the side. So this will give us a better view for any forward bend, arms, waist, what have you.
Okay.
Okay.
Same thing with the arms.
Yeah, yeah. And now when you're doing it, when you guys are looking and look at the example in your handbooks, basically the upper body and the shins should be at parallel. So you're pretty darn good. That's my dog. Just a little forward bend. Okay. Now while you're in motion, let's have you face that door, the one I keep having you face. Okay. All right. Can you step more toward the door for me? Sorry, the dog's whining. It's dinner time. Okay. Definitely I see that weight shift on the right leg, and that's affecting stability. Okay. Go ahead and relax. All right, you want to get yourself a drink of water or anything? Take
I
a
got
breath,
some right
and then we'll go into the goniometric measurements.
here.
All right.
All set.
Now for this, you could probably use the ball that you were sitting on originally. But if you have a chair, you can use a chair as well. Now in person, you guys, the perfect way to do. Hold on, let me give my dog a treat real quick. He'll be quiet, or we're gonna listen to this for a half hour. All right, hopefully that buys us a few minutes. Literally, like at 4:30 here, it's like she's like a alarm clock. Okay, what I was saying is in perfect situation, you've got a massage table and you can have somebody laying on it, and that's probably never gonna.
A table. I have my reformer set up if you want.
Okay, well that's a possibility. Or honestly, I don't need it, because here's the other problem. When we're doing it virtually, I can't get above you anyway. So I can't do abduction while you're lying on your back. But if I were there in person, I would absolutely be doing that.
Okay.
Make sure you guys watch the videos in Teachable where I'm actually doing it, it's like professionally filmed. So you'll see the difference of what it's like to do it virtually versus, here's in person. Now I got to listen to her chew. Okay, go out. Pets. So the thing about doing it like this is I am going to have you be very aware of your body in space. Okay. So when we are doing flexion, give me spotlight again, because let's assume you can't see me. When we're doing flexion, I want you in a straight line. Now, if your arm can't go up that high, that's fine. But I don't want you going out to the side, because now we're not in true flexion anymore. We're going into abduction. Now, the same thing when you're doing abduction, I'm going to be looking at you from the front, but I don't want your shoulder coming forward so you can lift your arm up more. So I tell people, imagine that there's two panes of glass, and that goes for whether you're doing this in person. Now I can't remove the spotlight. How do I? Okay, remove spotlight. All right, there we go. Now let's get your spotlight back. Okay, so probably, I think if you have your bench this way instead of sideways, so it's not going to interfere with your arms,
Okay.
and
Like this or horizontal?
um like perpendicular to your door. I can't see the bench anymore. There you go. Now
Oh,
I'm gonna yeah, yeah, you're good, you're good. Go ahead and relax. I just want to share this with you before we do this. So you guys can go to Amazon if you haven't got one or have never used one, and you can order two goniometers. You want a 6-inch goniometer for virtual because I have a 13-inch MacBook. So this little guy, I can actually hold it right up to the screen, perfect. And the little ones are pretty flexible. The 12-inch ones you want in person. They're more durable. They're going to be easier to read. And when you go to your goniometric section in the book, you'll read all about it and the norms, everything is in there. And also there's a video in Teachable. So there's three parts to this. The movement arm should always be on the outside. So this movement arm is like a hand on a clock. The stationary arm is what is attached to the circle. And then you've got your axis of rotation. So when you look in your book, it's going to say, align axis of rotation with shoulder joint, stationary arm in line with midline of the body, movement arm follows the arm. So as I do this, I'll describe each position for you. With flexion and extension, you're basically going about 2 inches below the AC joint. So I call this the squishy spot. If you were to lift your arm out to the side, you're going to feel an indentation right there. So it's basically in that space where the humerus goes into the shoulder joint.
am I too
Okay.
low? Is it?
That's probably a little low. It's probably up a little higher. And I'm going to do it visually when I do it. Like you don't even need to worry about it. But if I were there, I would be like, "Can I touch your shoulder?" And then I would find that spot. So that is going to be the same spot whether we go into extension or we go into flexion. Now, the norm for flexion is 150 to 180. So most people are going to be from here to here. That's my bad shoulder, so it's not going up all that way. Extension norm is about 40 to 60. Now, if I see you hiking your shoulder up or your head going forward or you're bending, you're compensating. So I want it to be as strict as possible. We want to try not to activate the muscles. Now, see, if I had you lying supine on a table, then it would be just gravity. But because we're doing this upright, I have to make a note to myself, or if I were sharing this with a therapist, that these were done upright because we're going to get a different measurement because you're working against gravity. Okay.
Yeah.
So extension, flexion for abduction, the axis of rotation is going to be right at the armpit. Norm is also 150 to 180, although other than yoga instructors, I've never seen anyone get 180. And the palm stays forward. Now, this is very easy to shift your shoulder and go all the way up. So what I want you to imagine is that you've got a wall behind you. Now, if you did it against the wall, I would say if this back of your arm below your elbow, if that starts to lift off, the humerus comes off the wall, or if you were lying on a table, then you've gone too far. So it's as far as you can go, keeping this flush with the imaginary wall, the real wall, or the floor or the table. Okay, that's abduction. Lastly, and this is the one I'll have you lie on your bench when you're ready or the floor. Just assume I'm lying down, and then we're going to do external and internal rotation. The axis of rotation is the elbow joint, and it's the same for both. Okay. The goniometer is perpendicular to the floor, and then the movement arm is either going to go forward or backward. Okay. The norm for abduction and flexion is the same, 150 to 180. This is in your book, so don't worry. The norm for extension and internal rotation is the same, 40 to 60, and external rotation is 70 to 90. Now, there are different standards used by different places. Like this is, I think, American Medical Association. I've been using these forever and ever. And we're not comparing you to anyone else. This is nothing more than a baseline so we can reassess you in 8 to 12 weeks and see that what we've chosen is working. Okay.
Okay.
All right. So why don't we begin with abduction? Um, if you put your legs together, then your arm can hang by your side. I want you to start with your palms facing me. And we'll just do one arm at a time. So let's start with your right. Imagine that wall, this imaginary wall behind you. and try not to lean your body. Stop at any point that you have pain. Okay, well, that's pretty remarkable. That's 180. All right, so now if you had printed off the thing in module 4, you wouldn't be making this little scribbly chart like I'm going to, but I am doing abduction. That was the right side, and that was a pretty straight 180. So let's see if the left side, with everything that's going on there, can do the same. Now make sure you don't shift. Okay, so at the very end, correct me if I'm wrong, go back down if you will. And I don't want to make you do this over and over, but I want
Yes.
you to get very cognizant when you get up to about shoulder height. I feel that you shifted your shoulder forward to get further up.
The
So I
skin's very tight from the
yeah,
radiation,
right
but
about there. You're like a little higher. I
I feel
think
a little tension. Yeah.
okay. So push past the tension a little, but not too much. Like don't force it up. I think that's about your norm. Okay. So I am taking this movement arm, and I am going to the actual elbow joint. So let me go ahead and relax. I don't want you to have to
Okay.
hold your arm up there. Um, so, 180 was straight up and down. Right. Now, if you take a look here, I have to like get clear here. So this is 140 and this is 130. So that means you're at 135 degrees. Okay. So the right side, now in the way I just had you do that with the left side, do you feel like you moved the right arm also, or do you think that was pretty the right arm?
Oh,
That was
no, I didn't. I
okay.
didn't.
All right. So we've got, whoops, 135. We've got a 45-degree difference. And it's obvious to me the reason why. You've got the expander, you've got the radiation, all that stuff. Could be scar tissue, could be adhesions. Now, the one thing that I will say is that you guys, when you're working with a client, they have to be 90% or better of the lowest number before you're going to add weights or resistance. The resistance could be holding a warrior one or a warrior two, anything that's going to be strengthening. So you are at 135, you're at that 90%. So I can start you with strength training. However, because I know that under normal circumstances, you could probably get that arm to 180 because that's what your other arm is at, that we're
Yeah.
still going to be working on range of motion for that.
Yeah.
Okay. So now I'm going to have you turn sideways. You don't have to move the bench, just your body. Yep. And we will do flexion and extension. So I'm going to find the squishy spot in my eye. The stationary arm will go straight down in line with your body or the seam of your shirt. The movement arm is going to first follow your arm forward into flexion, and then we'll go backward into extension. So we're going to do your left arm first, and
Oh,
your palm's going to face your body. Now, I want you to imagine me gently pushing your arm in so that it cannot go out to the side. We want strict flexion, okay?
mm. Keep going.
Yeah, I mean, until you can't or you feel like it's pulling too much or you're compensating. Okay.
No, I'm good.
So, um, and every now and then you're going to have your goniometer backwards like I just did, and you just have to do. All right, so you're at about 160. So that is the left side flexion, 160. And go ahead and lower your arm, and we'll do extension. Now make sure that you're not hiking up your shoulder. It's only as far as you can go without engaging those traps. Okay, so once again, the stationary arm is straight up and down. The movement arm is going towards your elbow. So I'm getting 45 degrees. Okay. So both of those are fine in terms of 90% or better. Now let's compare. So that was the more affected side. I mean, both sides are affected. So let's flip you around and do the other side. We're almost done, and then you can go have happy hour. Okay, so let's go into flexion first. Again, think about me gently pushing your arm towards you just so that you stay in that plane.
And then I'm raising it up.
Yeah, yeah. Thumb's gonna lead. Okay, and I'm taking this movement arm to the elbow. And it doesn't matter where your hand is. That's why you just want to take it to the elbow because it gives an optical illusion of that you're 180, but you're actually about 170, 166. Okay, so not that different than the other side. 6 degrees. Let's go ahead and go backward. Make sure that you're not elevating that trap. Okay, going right to the elbow there, and I've got 45, exact same. All right, and I'll explain this all afterwards, but now we're going to do internal and external rotation. It will actually be better if you could be on the floor, but I also want to respect immunocompromisation. I don't know,
Oh,
how.
it's fine. What do you
Okay.
need me to do?
So we're going to lower the camera or the whatever all the way down. So we're looking straight at you, and we're just going to do internal and external rotation.
Okay. On the floor?
Uh-huh.
So I'm lying on the floor?
Yeah. Um, I just
Here,
need.
why don't I do this? And if I
Oh
lie,
yeah, yeah, that's great. That's great. Okay, so let's pretend I'm on the floor here. Okay. So I
okay.
want your arm like this, and you can actually let your elbow hang off the end of the table, edge of the table if you want. So first, we'll do internal rotation. When you're doing internal rotation, and I know this isn't how we would do it, you want to make sure that you're not protracting that shoulder anymore. So kind of like extension. You're just
So you mean hand over belly
no,
button
no.
down?
So it's like if I'm lying down, this is what my arm's going to be doing. So it's going to be out at your side, just lower than shoulder height. Yeah, hold on. Let me get you back here because I'm looking at myself, which is not good. Let's see. Okay. Yes, perfect. All right. So I actually want you to keep your knees bent. A, because it protects your back, and B, because it keeps you from cheating. Now the only issue is you're a little askew. So can you move your hips over more towards your mirror? Okay. That's great. Now what you're still kind of in an, you know what it is? Your computer, I think, is not square at the table, at the
Okay.
reformer. Better. Yes, thank you. Because that can totally change the picture. So now if you can move towards your mirror and then drop your arm a little bit so it's just below shoulder height. Okay. Now I can't actually see your elbow, but I know where it is. So I'm going to hold my goniometer. The axis of rotation is going to be right at your elbow joint. First, I'm going to have you go into external rotation, but hang on a second, because I want you guys to think about as she goes into external rotation, she's pulling against that expander. She's pulling, she's got the radiation issues, all that stuff. So think about that, when you're having a client do a particular exercise and understand why they may or may not be able to, or they have limited rotation. Okay. So let's go backwards first into external rotation. Okay, so your arm is lying on that table. That tells me you're 90 degrees. I don't even need a goniometer. So that is left arm external rotation, which is pretty miraculous with everything your body's going through. All right, now let's go back up so your arm is perpendicular to the table. As you go forward, palm facing your toes, your feet, make sure that you don't let that shoulder pop up. So right about there, if you start to feel your shoulder coming off, you feel it coming off of the table? Yep. See that's too much. So it's kind of like just letting your arm fall forward a little bit. Too much. Shoulders off the table.
Really?
Yeah. I mean, from my perspective.
I feel my shoulder blade. So
Okay. So here, do this. Take your left fingers and put it on right underneath your clavicle. I'm sorry, your right fingers. Okay, on your left clavicle.
oh,
Other
sorry.
Okay. Now, as soon as you feel the muscles start to tense underneath your fingers, that's a pretty good. Now, if you're on the bone, you want to be below the bone. So you're on the actual muscle. So if you feel the muscles start to contract, that's usually when I tell people to stop. Okay. All right. So we are at right about 60 degrees, which is great. Norm is 40 to 60. All right. So then if you can just flip all the way around, we'll do the same thing on the other side. And you guys, when you're doing these, you're not, no worries, Amanda. You're not trying to get the best of three or anything like that, because obviously the more times somebody does something, the better the range of motion is going to get. All right. So get that arm out to the side, just like we did with the other. I've got your body kind of angled again somehow. If you move more towards your mirror a little, like move your tush over. Yeah, let's try that. I don't know if that'll do it or not, but go ahead and bend the elbow. right there. Beautiful. Now, if you go back and you touch the reformer pad, then I don't even need my goniometer. So let's see if you can go all the way back. Yeah. Okay. Done. Done deal. All right. Now, as we go forward, if you want to try that again, taking your left fingers, putting them under your clavicle on the right side, as soon as you feel that tension, then that is it.
I don't feel tension
Okay. That side. Yeah.
right here.
So
Now it moves.
your shoulder pops up a little bit. So right there is where I start to see too much movement. So
Yeah.
it's not too different. I'm getting maybe 5 degrees more on that side. So 65. All right, so you get comfortable. We're going to wrap this up, but put your jacket on if you like. Let me remove your spotlight. And what I will do, more than likely, I'll do it tomorrow morning. In your Teachable, where this recording is, in the text, I will add all this. Okay. So then, I don't know when I want to say maybe it's next Thursday that we actually do the exercise programming. So between now and then, you can go ahead and, look at all the postural things and then go to page, I believe it's page 16 in module 3. And you'll see the chart and you can be like, oh, okay, these muscles are tight, these muscles are weak. We need to stretch these, we need to strengthen these. And then there's suggested exercises, not for everything, but you'll see forward head, scapula, anterior pelvic tilt. So just start to formulate, you guys, like, you're a Pilates instructor. What Pilates exercises would you do to correct anterior tilt? What Pilates, Now we also have to keep in mind that although we might want to do a barrel hug because, we want to stretch your chest, that we've got expanders in. So right now, we're not doing any chest or back.
Oops.
You're going to need to, but not right now. You can do isometrics. So you can squeeze your shoulder blades together, and that's about it for now. Okay. So this is what we're going to do. We're going to do next week. I'm going to take this step by step. We're going to go through all of the side effects of the treatments. We're going to go through your surgeries. Um, then you'll look for the squat test and you'll also see a chart like saying these muscles are doing this and that. Really the two things that I really noticed was the forward bend at the waist and then that weight shift. So there's, this mystery thing going on your left side, which I want to get you doing some QL stretches, and I think that's the culprit. But then the opposite of tight QLs is weak rectus abdominis. Bingo, you've had 7 abdominal surgeries.
Yeah.
Okay, so this is where, like, when you look at these charts, you go, okay, well, this is tight, but oh, these are weak. And I guarantee you, as we go through these, we're going to see connections with your calves, with your Achilles, with your knees, with your hips. It's the kinetic
Yeah.
chain. Lastly, we've got your range of motion. There was nothing that was not at least 90%. So that means
Okay.
you're not limited, like in this particular case, um, I was going to use the word Trumps, but now I feel like I can't use Trump. I'm like too politically charged. But
Yeah.
using the word Trump meaning to outdo. In this particular case, we're not worried about range of motion trumping strength training. Like your range of motion's good enough that we can start on strength training, but we'll still be doing range of motion exercises, particularly with abduction, which was the only one there was a significant difference from side to side. Everything else was either identical or within just a few degrees different. So I don't even need to like pay attention to that. I'll post this tomorrow.
Okay.
You don't have to worry about it. Have your weekend. You guys don't need to look at this tomorrow. And then throughout the week, maybe just start experimenting a little bit. Once I post, obviously, all of your treatment, but for the rest of you guys and those watching the recording, look at these treatments, look in your book, look at the side effects, and based on the fact that she's only 3 months out of chemo. What side effects are we still concerned with? Based on the fact that she's going through photon therapy, what side effects are we concerned with? I've talked about some. We've talked about platelets. We've talked about bruising and bleeding. We've talked about fatigue. We've talked about the expanders. So just give it some thought. If you don't give it any, so be it. We'll do it all together next week. And then, we're going to address peripheral neuropathy in the upper and lower body. We're going to address the lymphedema in the upper body. cording and then the whatever swelling is going on. But I would just to suggest this to you over the weekend or the next week, try the lower extremity lymph drainage exercises and just
Okay.
see if you get any relief. I mean, do them all, do the upper body too, because
Sure.
you need to do that.
Yeah.
But because the upper body opens up the thoracic duct, which is the most responsible for lymphatic drainage in both the upper and lower body. But I would do the supine leg exercises as well and see if you get some relief.
Okay.
So anybody have any questions before we go? I know it's dinner time for everybody or later. Hopefully this gives you some insight as to this process. Like I said, Suzanne, you're a great example because, it is not complicated, comprehensive. I mean, there's a lot to consider. So you can imagine if you were to go to, XYZ Fitness and get some newbie, how dangerous it could be. Not dangerous.
Yeah.
You're gonna, not mortally dangerous, but you could really get hurt. And that's why what we do is so important, and we need to do it right, and we need to do it with precision. So
Great.
on that note, yeah, thanks, Anne. Amanda, Nicole, you guys good? You could do a
Yep,
thumbs
all
up.
good, yep.
Okay,
Yep.
okay, cool. Where do you live, Amanda?
I'm in Scotland.
Oh, I love it.
Hello.
Yeah.
I detect an accent. And where are you, Anne?
I'm in Queen Creek, Arizona.
Okay, and I don't know if Nicole's there, but if you are, you can
Yeah.
tell us where you live. All right, well, Scotland's on my bucket list. Arizona's too hot for me.
Not this time of year. It's perfect.
Yeah, I bet it is. Okay, Nicole's in Wisconsin, so she's probably got some cold weather. Well, we've been in like single digits here. It's been unbearable. So I'm in Colorado. And so Suzanne, if you ever or anybody wants to come skiing or snowboarding, I'm between Vail and Beaver Creek. So
Absolutely.
Oh, brilliant.
None of
but
it
I'm,
passed.
I'm being really lazy this year because I had back surgery in August. So A, I'm scared to death, and B, it's so friggin' cold. I can't stand it.
Yeah. Yeah, for
All
sure.
right. Well, you guys have a great weekend. Thanks for being here, and thanks, Suzanne, for doing this. So go
Thank you.
treat yourself to something yummy, and we'll see you. Like I said, I think it's next Thursday. I'm not 100% sure. I gotta look at my schedule myself.
Thank
But I'll be
you.
there. And Suzanne, you don't have to be there. Well, you're in the class anyway, so you probably want to be. But I was gonna say if the time doesn't work, it's not like today where we actually physically needed you here.
Yeah.
So,
Okay.
all right, and we'll all do it together. So be prepared to be interactive.
Okay.
All right, you
Thank you.
guys.
Perfect, thank
Bye.
you.
Thank you.
Have a nice weekend.
Bye-bye.
Bye, bye-bye.
You too.
Yeah.
Bye.